So Jazzmun, do you want to come up to the podium and introduce yourself?
Great.
Thank you so much. It is customary to acknowledge the land and territories of the indigenous people on which we stand on. The land we are currently on is the traditional home of the Tongan and Chumash people. Both the Tongan and Chumash peoples have charged those of us who are guests on their lands to be good stewards. This includes being respectful to the plants and animals who came before all of us, not littering, respecting sacred sites, and honoring one another. In these ever-changing times where TGI lives are being used as political warfare, women's wounds are being treated as state property, and the unhoused communities continue to be pathologized and discarded, more intentional programs must be developed and implemented. At this very moment, we are in a state of emergency that needs our immediate attention, and we must fill in the gaps. Because if we don't, families and communities will continue to be dismantled. Health disparities will continue to increase, and the dehumanizing of disenfranchised communities will continue to erode and challenge the integrity of our society. But there is hope. And I am in a celebratory mood today. I'm grateful to the scientific community for the advances you have made in medicine that have prolonged the lives of people affected by and at risk, I know you said not to use it, but at risk of HIV. I'm also grateful to our federal partners that support the science, and to all the community partners, stakeholders, and my fellow colleagues who are here in this room today for your commitment, your service, and grit to end the HIV epidemic. As you know, there is so much more we need to do to make that happen, and that is why we are here today. I am proud to be here to be a partner in this fight with you. I am Jazzmun Nikela Crayton. I use glamorous feminine pronouns, and I am gender fierce. I come from an entertainment background, and this is my 10-year anniversary working in the nonprofit sector, where I've gained a wealth of knowledge and experience. Under the supervision and the leadership of my director, Mr. Jerry Candelario, our agency, APAIT, opened the first federally funded interim housing program, Casa Zuma, specifically for trans women. Every day and night for 365 days a year, 7 days a week, 24 hours a day, a woman of trans experience gains more agency and the ability to live a more intentional life at Casa Zuma. I feel fortunate that every day I witness a miracle. To quote Marianne Williamson, a miracle is just a shift in one's perception. Today, as we gather here to embark, someone's calling me, excuse me, my colleagues. They're at Casa Zuma. Today, as we gather here to embark on a learning adventure, let's remain open to new information and ideas. Let's be willing to explore new perspectives. And let's be brave enough to call it out where we might fall short in our efforts to challenge ourselves to be creative, and for us to continue to innovate so that we can better serve our community and truly end the HIV epidemic. Because together, we really can inspire change. I leave you with this quote from Dr. Cornel West. You can't lead the people if you don't love the people, and you cannot save the people if you don't serve the people. Thank you.
Wow, thank you. So now what I'd like to do is have each of the panelists introduce themselves. Starting with Mary, or actually, why don't you
Oh,
introduce
sure.
yourself again? Yeah, thank you.
Hello again. My name is Jazzmun Crayton. I am the Associate Director at APAIT here in Los Angeles under SSG, Special Service Groups.
Good morning, everyone. I'm Mary Glenshaw. I'm the Acting Deputy Director of the Office of AIDS Research at the NIH. I'm here on behalf of our Acting Director, Dr. Deanna Finzi. Thank you.
And I'm Paul Weidle. I'm with the Division of HIV Prevention at the Centers for Disease Control, and I'll be talking about a little bit of our activities when I present.
Good morning, everyone. My name is Pamela Klein. I'm with HRSA's HIV/AIDS Bureau in the Division of Policy and Data, where I'm a branch chief.
Ani, good morning. My name is Rick Haverkate. I'm an enrolled member of the Sault Ste. Marie tribe of Chippewa Indians from Upper Michigan, but I serve serve with the Indian Health Service as the branch chief for their HIV, Hep C, and STI program.
Good morning. Buenos días. Bienvenidos. I'm Mario Perez. I'm the director of the Division of HIV and STD programs for the LA County Department of Public Health.
And then I know we have one more colleague who unfortunately is not able to be here, Ms. Kristen Rojas from SANSA, and I think there's a short video from her.
Hello, my name is Kristen Roja, and I'm a public health advisor with the Substance Abuse and Mental Health Services Administration, or SAMHSA. I'm so sorry I can't be there with you in person today. Thank you to the organizers for allowing me to submit my remarks virtually. SAMHSA's mission is to lead public health and service delivery efforts that promote mental health, prevent substance misuse, and provide treatments and supports to foster recovery while ensuring equitable access and better outcomes. SAMHSA envisions that people with, affected by, or at risk for mental health and substance use conditions receive care, achieve well-being, and thrive. We know that for many of the people we serve, their first and possibly only touch point with the healthcare system may be through their SAMHSA-funded substance use or mental health provider. That's why the integration of behavioral and physical healthcare is one of 5 priority areas highlighted in SAMHSA's Strategic Plan 2023 to 2026. This focus on integrating behavioral and physical healthcare allows SAMHSA to fund whole person care that addresses the complex needs of individuals with, affected by, or at risk for mental health and substance use conditions. SAMHSA participates in ending the HIV epidemic in a variety of ways. Our Minority AIDS Initiative funded grant programs focus on substance misuse prevention and substance use disorder treatment for people who are at risk for or living with HIV, and the integration of mental health care into HIV primary care settings. For the past few years, our Minority AIDS Initiative funded grant programs have prioritized applicants serving people in the EHE jurisdictions. We've done that by awarding additional points to those applicants, a change that increased the number of grant recipients serving those jurisdictions by nearly 40% in its first year of implementation. SAMHSA funds implementation grants, and applicants are not generally required to incorporate research into their SAMHSA-funded work. However, many grant recipients do conduct implementation science research as a component of their SAMHSA grant. SAMHSA encourages grant recipients to innovate and try new approaches to serve their populations of focus. This innovation can take the form of adapting existing cultural or evidence-based practices for new populations, or layering different interventions together in new ways to treat the whole person and respond to the specific needs of their population. Finally, I do want to mention some of the resources that SAMHSA has available to the public. These include our Treatment Improvement Protocol, or TIP series, and our Evidence-Based Resource Guide series, both of which are available on SAMHSA's website, and both include resources for the integration of behavioral healthcare and infectious disease services. SAMHSA also funds 3 technology transfer centers, one each for addiction, prevention, and mental health care. The purpose of these technology transfer centers is to develop and strengthen the specialized behavioral health care and primary health care workforce that provides prevention, treatment, and recovery support services for substance use disorders and mental illness. SAMHSA is proud to work alongside our federal partners and members of the community to work together to end the HIV epidemic. Thank you very much.
Great, thank you. So now what I'd like to do is give our panelists an opportunity to give a couple remarks, starting with Captain Mary Glenshaw.
Great, thank you. Good morning, everyone. If I was in South Africa, I would say, good morning, everyone. Thank you, thank you, thank you. I know it's early. So just a couple of remarks from NIH to help frame where we are. A bit of a history lesson. In 1988, Congress authorized the OAR to oversee, coordinate, and manage the NIH HIV research portfolio. We collaborate across our US government partners and with researchers, community groups, and global partners to identify priorities for HIV and HIV-related research. OAR helps coordinate and manage the 22 NIH institutes, centers, and offices that participate in NIH-supported HIV research. The EHE working group at NIH is also comprised of a diverse set of ICOs, including NIAID, NIMH, NICHD, NIDA, NIAAA, NIA, NHLBI, NIDDK, Fogarty International Center, FIC, and SGMRO, which might be a new one for you, which is the Sexual and Gender Minority Research Office. Many of these representatives are here or listening today. The NIH research agenda is guided by a whole-of-government approach, as we all know. The NHAS, or National HIV/AIDS Strategy for the U.S., the NIH Strategic Plan, as I mentioned, and of course, EHE. These frameworks all complement each other and work in concert to guide the basic clinical, social behavioral, and implementation research priorities and translate these into public health policies that improve the lives of people living with HIV. Through the EHE initiative, NIH continues to support implementation research to develop and refine innovative, evidence-based approaches to expand testing, prevention, treatment, and response services in communities disproportionately affected and impacted by HIV. By using systematic research methods, we can inform locally relevant, high-quality, and effective service delivery activities of all of our partners. So for fiscal year 24, the $26 million allocated to the NIH will support 50 ongoing implementation research projects that collaborate with community partners, 2 coordination centers to harmonize and synthesize data across projects, and 8 regional consultation hubs to provide technical assistance to the project teams. In addition, the projects supported in 2024 will include administrative supplements, as many of you receive, to the multi-sectoral CFARs and AIDS research centers, or ARCs. And this time will also include larger research projects initiated by independent investigators, some of which may be funded by other ICOs. NIH, to this end, we issued a notice of special interest and recently just reissued it, or plan to reissue it, for fiscal year 24. And this NOCI aims to expand and improve engagement and re-engagement in HIV services with interest in unstable housing or homelessness and communities affected by clusters and outbreaks. It also aims to scale up strategies to deliver integrated, call it syndemic, HIV prevention, treatment, and care services to address the comorbidities, co-infections, mental health conditions, and other conditions, including underlying social determinants of health that adversely affect outcomes. NIH EHE projects enable academic institutions to partner with state and local leaders, as many of you represent, to jointly translate implementation research findings into improved delivery of HIV testing, prevention, treatment, and response services for priority populations in priority geographic areas. So looking forward, just stepping out a bit of EHE, we are also developing the next 5-year strategic plan for HIV research at the NIH. This plan will guide priorities for the entire HIV research program. Please join my colleague Amber Wilson and I this afternoon, if you have time, at about 4 o'clock, so that you can tell us what your ideas are for new and innovative HIV research areas in the next strategic plan, including and beyond EHE topics. Thank you.
So I'll talk a little bit about what we're doing with CDC. So CDC uses both the National HIV/AIDS Strategy and EHE as a guide for the work we do. Our efforts will continue to focus on the 4 main strategies identified as critical to ending the HIV epidemic, which include diagnose, treat, prevent, and respond. The strategies we take to achieve these goals include partnering and funding prevention program, HIV surveillance, community engagement, capacity building, communications, and research. We recently published our largest public health funding announcement to date that will provide funding to 60 health departments for core HIV prevention, HIV surveillance, and community engagement. And within that, there are an additional 32 awards that are available to the health departments to support the 57 EHE jurisdictions. At level funding, this will be about $485 million per year, about $2.4 billion over 5 years. Our HIV surveillance branch produces the data that are used for the EHE dashboard that monitor progress for EHE. Our sister division of STD prevention will support and scale up HIV prevention services and sexual health clinics with EHE funds. This is a follow-on to the work that they started with the original CDC EHE funding, and they anticipate 20 awards at approximately $1 million per award that would all start in June. We just also published our funding announcement for capacity building activities to follow on the previous capacity building activities funding. And we expect to award up to $127 million over 5 years, not per year, but over 5 years, to an estimated 15 organizations to strengthen capacity and improve the performance of the HIV workforce. So that's kind of the new stuff that's coming, and there are a couple of existing funding streams for community-based organizations. One that was first published, most recently funded in 2021 for 96 CBOs, where we fund the CBOs directly, and another one in 2022, which focused on CBOs serving young men of color and transgender persons of color. And there are 36 CBOs funded through that award. Our implementation resource portfolio is guided by our internal science agenda, which is aligned with our priorities. A few examples over the last 2 years, announcements that have gone out. There are other projects that are in the field as well. Our Minority AIDS Research Initiative is entering its 6th round of funding. It's been ongoing for 20 plus years, and it's trained and mentored 42 early career scientists underrepresented in HIV research. HER-PrEP is a project to evaluate strategies to increase HIV PrEP use among Black, African American, cisgender women. And then we have a number of projects looking at best practices for ART, including long-acting injectables, rapid start in ERs, telehealth services for recently incarcerated persons, and some others. And there's a project to develop a community health worker-mediated approach to re-engagement in care and outreach services for persons with HIV in rural communities. And also an HIV and aging and investigator-driven research project to explore and identify factors related to quality of life for persons with HIV age 50 and older. In terms of, we also have a compendium of evidence-based interventions and best practices for HIV prevention, which categorizes interventions as evidence-based interventions or evidence-informed interventions. And there are 5 chapters. One for PrEP, one for linkage, retention, and re-engagement in care, one for medication adherence, risk reduction, and one for structural interventions. Last thing I'll say is community engagement is important to CDC. We fund the health departments to keep community involved in the work that they do. But in 2022, we started doing virtual community engagement sessions around the country. We did 16 of them in 2022, and then in 2023, we partnered with HRSA to do some sessions as well in 2023, and then at the end of 2023, the division started to do in-person sessions with community-led and community-serving organizations in the South. And with that, I will stop and turn it to my friend.
Thanks, Paul. Good morning, everyone. I need to adjust myself, so there's a timer down here, and I'm a little too short to see it without leaning forward really awkwardly.
You did great. I didn't.
So first, I'd really like to thank the hosts and the organizers for inviting HRSA to be a part of this exciting panel and this meeting. HRSA has been partnering with NIH and other federal agencies for many years and has collaborated many times with CFARs, ARCs, and many of the implementing partners in the room today. And personally, I'm really excited to be here as I did my graduate training at a CFAR and my postdoc training at an ARC, so this is really cool for me. HRSA implements EHE primarily through the work of two programs. The Health Center program, administered by the Bureau of Primary Health Care, which addresses the diagnose and prevent EHE pillars, and the Ryan White HIV/AIDS program, which is administered by the HIV/AIDS Bureau, which addresses the treat and respond EHE pillars. So first I'll talk briefly about the Bureau of Primary Health Care. They fund health centers to expand prevention services that decrease the risk of HIV transmission through the EHE Primary Care HIV Prevention Program, or PCHIP, because we love our acronyms in the federal government. This program includes the use of PrEP, testing, outreach, and care coordinations at health centers in EHE jurisdictions. And in 2022, HRSA-funded health centers performed nearly 3.5 million HIV tests, and nearly 200,000 people with HIV received primary care services at these health centers, many in settings that are jointly funded by the Ryan White HIV/AIDS program. And nearly 85,000 people received PrEP services. 65,000 of them were in EHE-funded health centers. So the HIV/AIDS Bureau currently funds metropolitan areas and states that make up the EHE priority jurisdictions. And these recipients are funded to implement strategies and interventions to optimize care and treatment for people with HIV. These recipients implement activities focused on those not yet diagnosed, those diagnosed and not yet in care, and those who are in HIV care but not yet virally suppressed. In 2021, the HIV/AIDS Bureau EHE-funded providers served more than 37,000 clients new to care or estimated to be re-engaged in care. Of the clients who were new to care and received HIV treatment through the Ryan White program, 79% reached viral suppression within that calendar year. And this demonstrates that these providers were very successful in rapidly engaging clients new to care, likely leading to a reduction in HIV transmissions. The HIV/AIDS Bureau also funds the Ryan White Part F AIDS Education and Training Center program, or ATC program. And through this, for EHE, these recipients are funded to provide workforce capacity development and technical assistance, specifically in EHE jurisdictions. So from July 2021 through June 2022, the regional AATCs conducted 335 EHE-funded trainings, reaching more than 3,200 HIV clinical and non-clinical professionals. There are two additional organizations funded through EHE by HRSA, a technical assistance provider and a systems coordination provider. Together, they support recipients with technical assistance and healthcare and social systems coordination. And over the last 6 months, these organizations have hosted a series of intensive TA workshops for the EHE-funded jurisdictions, focusing on identifying big bets that the jurisdictions could implement during this last year of the current funding cycle. Now, the HIV/AIDS Bureau is very excited that Congress passed a budget that includes HRSA's EHE funding so that this important work can continue. Moving forward, our vision of optimal HIV care and treatment for all to end the HIV epidemic in the US calls on us to focus on reaching people with HIV who are out of care while continuing to address the disparities among our current clients. The work of the HIV/AIDS Bureau's EHE recipients and providers is already making a significant contribution to reaching the over 200,000 people with HIV who are not in care. So we'll accomplish this by leveraging partnerships, focusing Ryan White program resources, and community engagement. And for us, partnerships and community engagement with community members means engagement from planning through implementation and into evaluation and dissemination. And thanks, Paul, for mentioning the community engagement sessions that CDC and HRSA worked on together over the last year. Underpinning all of these activities are implementation and dissemination science. And we need to better understand what works, how it works, and how to get what works in the world so that it can be implemented and replicated. So I look forward to learning from and working with all of you over the next 2 days at this meeting and as we continue our collective work to end the HIV epidemic.
Hi again, Rick Haverkate with Indian Health Service. Thanks for all that good, encouraging news. It's really nice to hear that. But how many thought, okay, now that's next for Indian country, you're going to get some bad news? Be serious, right? We always get up and tell our bad news, but we have a lot of really good news in Indian country because of the Minority HIV/AIDS Fund, because of ending the HIV epidemic funds to the Indian Health Service, which we in turn give out to our tribal and urban and IHS programs. We have been seeing some good news. Incidence rates have edged down a little bit. Prevalence rates keep going down. Diagnoses for HIV is going up. We're doing an excellent job training our clinicians to offer testing anyone 13 years and over. And our clinics, some of our clinics, in fact, are doing such good work with their HIV testing that they're like, what do we do next? We have to make more babies because we don't have anyone else to test. So they're doing really good, especially in some of our maternal child health programs. They're screened more than 95% of pregnant people in some of our tribal communities. So really, really good news. And a lot of that has to do with the partnerships we've had with the other folks in the panel, our fellow government offices, but so much of that is done because of the work we're doing at the local level. So our tribes, our urban programs, our IHS facilities have this innate kind of urge to really give programs to their communities in the way that they perceive them to be the best, the way that they learn the best, the way that they speak, the way that they interact with health services. And I think a lot of times we're trying to figure out what doesn't work and why doesn't it work. And I think some of that has to do with the idea that, do we really get to know our communities? Is there really such a thing as cultural competency? I think there is, but I also think that we need to make sure that when we're going into communities that we're not from, we recruit people from that community, because I think the perceptions really get a little bit mixed up sometimes. Well, I have this great service, why aren't you taking it? I mean, we told you to go to 3 prenatal screenings for syphilis, why didn't you do it? And are we really feeling what they feel? What is it like to have to schedule an appointment if I'm houseless, if I am using substance and I have to disclose that in a clinical session where I may or may not be charged with a crime because I might be pregnant? So what is it like to be walking in those shoes? So we have to think about what is it like to have that knowledge from that community as we go into our programs. Luckily, with the little bit of funding, you saw this screen on the board a little while ago, IHS got $5 million in EHE funds. On top of that, we do get minority HIV/AIDS funds each year. 100% of that goes through my office directly out to our tribal programs. And we've been doing some amazing things in tribal country, training physicians through things like Project ECHO, making the best use of the national initiatives like the STI and HIV and viral hepatitis. And we combined all of those with MAFE dollars. We combined all those into one thing called the Indigenous HIV Syndemic Strategy. We nicknamed it IndigiHOS. So it's a way that we work with our communities to devise a system of approach that really came from them. And I was scholared by a really good community partner. I was calling it, we indigenized the strategies. And they're like, no, we didn't. We created something from an indigenous perspective. So it's an indigenous approach to the strategy. It's not indigenized. So think of that too as we're coming in with ideas for programs or research. Don't just change a couple of words, put a picture on it, and think, oh, well, now that speaks to indigenous communities. Really make sure, I think, that we go in and talk with our communities. How is it designed from their perspective out, not from the outside in? I really wanted to give a shout out to our IHS leadership, our previous director, Michael Wiyaki, who was at the start of the EHE efforts, and now our new director, Ms. Rosalind So there. They really care. They really encourage us. Get the funds out to our tribal communities. Don't keep them back at headquarters, knowing full well there's some inherently federal obligations that we have, like overseeing grants, but we really try to get funds out, resources out, projects that the communities run, things like Project Red Talent out of our partners at the Northwest Portland Area Health Board, the project that our Southern Plains Tribal Health Board is working on with Johns Hopkins, I Want the Kit. So now people have access to online ordering for HIV, STIs, even pregnancy tests now. And we're really looking forward to some future funding so that, it used to just be me at the Indian Health Service office at headquarters. Now I have 7 staff working for us. Thanks to EHE, we can really meet the needs, meet requests, respond to our federal partners, and respond to our community. So we look forward to keeping up that good work. And just a shout out, who is here from Indian country? Well, we see a few. But I also wanted to say 1 second, so who in here works for or with Indian communities? Very nice. But I would challenge you all to raise your hands because I bet you don't even know it and you are working with and for Indian communities.
Good morning again. Buenos dias. So I've got 5 minutes to describe our role with EHE. So I've got 7 bullet points, but there's probably about 8 that I'm missing. Our primary role is to take the very de-siloed investment in the HIV response and try to de-silo and invest about $100 million to support the most progressive programming we can. That means taking federal, state, local resources and operationalizing them through more than 60 community-based organizations, FQHCs, partners in our department. An unenviable task, I might say. We are the ones who try to operationalize the syndemic planning that many people talk about. We try to take resources and push the envelope, use them creatively in the midst of sometimes some very rigid federal rules around how we can and can't use resources. Our job is to maintain the existing partners who are helping end HIV, and sometimes that is daunting because there's significant burnout. The healthcare workforce is taxed, and there are folks who continue to give up contracts. Our job is also to enlist new partners, and we've tried to do that broadly through existing healthcare delivery systems who have not prioritized HIV, STD, MPOX, SUD, mental health, homelessness, and to try to encourage them to take their existing infrastructure and with some enhanced funding, help us do more. We also have a role catalyzing adaptation. We're a Medicaid state in California, one of the early adopters of Medicaid expansion, and Medicaid is transforming how we support our work. But expansion also requires that we adapt to those funding streams. We also need to adapt to how existing resources can be used, and sometimes that is an uphill battle. We're expected to spur innovation, and we relish being disruptively innovative. It was a charge given to us by the former CDC director many years ago. We've taken that to heart, and tomorrow I'll have a chance to share some of the things we're doing in LA County to innovate. We are expected to support translational research, to take everything that our academic partners, our research partners are discovering and learning and put that into practice. And that has been, that's been slow, but it's absolutely necessary. We're also responsible, given our management of data, surveillance, and epidata, to have data use agreements in place. And we relish sharing the data that we have. You know, we have some very rich repositories of information, and we need to do more of that. And we have some academic partners here in the room who we enjoy very productive relationships with those data use agreements. But that research that's born out of those data use agreements absolutely must be used to benefit programs on the ground. It can't simply be for enhancing a research agenda without translation. We're expected to support the workforce, as I mentioned earlier, that's increasingly taxed. We help reset program priorities, try to get people more aligned with what we're trying to do across the 4 pillars of EHE. We have to help with resource coordination, help FQHCs figure out how best to appeal to CMS in the state to get their revenue to be commensurate with the efforts we expect. We have to balance cost neutrality while incentivizing program performance. So we think we have some pretty creative ways to finance the work, to build in incentives so that we get the most production out of those investments. And we also have a role at the local health department to appeal for more progressive budget policy. I think we need to modernize the Ryan White program. It's been way too long. We've got 40 states that are Medicaid expanded. We've got 10 in the South, and I think there might be a correlation between where we're seeing growing HIV impact with the failure to expand Medicaid. But we have to make sure that on the ground, revenue streams are in harmony as best as possible. And we also need this is a more recent appeal to us, is we have to be less administratively burdensome. And I think we've heard loud and clear from our partners that the admin expectations, the data collection is really impinging on people's ability to have the greatest impact at the ground level. So those are the things that, those are our roles. I'll mention one more thing that I find myself in. We're also increasingly defenders of cluster detection and response. And we've engaged the community, but there isn't as widespread an appetite for CDR as we would think. We think it's a very important tool in LA. We absolutely want to avoid outbreaks, but that means that we wear a different hat, trying to convince our other sister health departments and community members of the potential benefit of cluster detection and response. So those are my early offers. I'll have a chance tomorrow to offer a few more thoughts on our response to the HIV epidemic in America.
Thank you. Thank you to all our panelists. So we do have time for one or two questions. I do want to remind everyone we're going to invite our panelists back up here after our next presenter. So do we have a couple questions from the audience? If we do, please come up to the mics.
Dale, and I'm from the University of Miami. To the last speaker, and I wear many hats, so I'm going to access on behalf of United We Rise, which is a collective of Black scholars, activists, and others engaged and committed to ending the HIV epidemic in Black communities. When you talk about the administrative blocks that people talk about that get in the way of actually doing the work, can folks comment on what they imagine could be revisions to application processes to secure funding? When COVID happened, there were a lot of changes to allow organizations to be able to tap into funds to do the work quicker. But the status quo is a longer, more tiresome, again, a lot of administrative blocks to people actually getting the money to do the work.
Couldn't agree more. During COVID, we broke and bent every procurement rule on the book to get billions of resources tied to COVID on the street. And we have not adapted that same approach with, arguably resources that should be on the street as quickly as possible. So I think there's huge opportunities there. The county has a reputation of having a very slow procurement process. We've enlisted a third-party administrator, Haluna Health, to help get over $10 million on the street in a very short amount of time, and that's been, I think, really, really important, so that we take the spirit of EHE, the resource tied to EHE, and really have impact sooner. But we should continue those exceptions and bending of the rules.
Great. Any other questions? Yes, please.
All the way on your left, Tom Bellin. I'm with the UCLA-based CHIPTS Center for HIV Identification, Prevention, and Treatment Services. With all the researchers in the room, I was just wondering if any of you could comment on strategies for dissemination of research results that you've found to be especially helpful or successful in accelerating the dissemination of relevant information.
I can take a stab at that one. There are a number of dissemination strategies, and arguably we need many, many more. particularly strategies that translate findings to the real world context. What does this mean for you? How can you adapt this to your setting? For the more academic slant, I want to give a shout out to our colleagues at ICSE who have dashboards and tools to really dive into implementation research, methodologies, areas of focus, populations, et cetera. And it's an absolutely untapped resource, in my opinion, that I think could be shifted and molded to have more translational qualities, but it absolutely has incredible academic qualities. So I encourage you to check that out if you haven't yet. And I will say, you know, I think in this position, I've really come to value HIV.gov. HIV.gov is really exploded. They are sharing information across sectors in unique and innovative ways, and are really on the ground and doing fantastic work. So I think we should give a shout out to HIV.gov as well. Thank you.
Please, yeah.
Thanks. And if I could also respond, you know, I feel like if you're going to shout out HIV.gov, I also have to shout out Target HIV, which is a really fantastic resource supported by the Ryan White program for getting information out to implementers. And one particular resource that I want to highlight is our best practices compilation, which currently has over 95 evidence-based, evidence-informed, and promising practices. So some have, there we have the whole spectrum of evidence base there, but it's filterable by different populations and different settings, and it's really a fantastic resource for people to go and see what is there, to nominate other great work that you're seeing in the field, to share what you find is working on the ground. But there's of course more to be done. We through our Special Projects of National Significance program often put out toolkits and manuals and guides, but we are also doing an evaluation of these products to see, is this the best way? And so some of you in the room might be participating in a project that we have right now called the Rapid Uptake of Disseminated Interventions, or RUDI, because again, acronyms. And through that project, we're looking at how our implementation products are being taken up and getting feedback on all of these products. So thanks to any of you who are participating in that. But I think Linda Koenig and I will be talking a little bit more about this tomorrow morning.
Great, thank you. And then last question, please.
I'll be brief. I just wanted to follow up on Sanisha's question because I think it's really key. And, for those of us doing implementation science, fiscal, finance, that burden, getting the money, being able to turn it around is like a shared barrier across any program that you're implementing. So I just wanted to urge, like this interagency collaboration that exists is incredibly powerful around programs. It's really inspiring, but there's that boring thing that is fiscal and admin that is getting in the way of that great work. So just if you could add this to the list of interagency, because it's happening at a national level, like at an HHS level, as opposed to each individual agency. So just a plea.
Thank you. Would any of our colleagues like to provide feedback on the last comment? No, okay. No pressure.
We understand, and I think we understand, and I think we can definitely keep it on the radar between the interagency groups.
Yeah, and I will just add, being in the community in the region, we've heard that over and over, and that is definitely something that the principals are discussing, so absolutely. So thank you all so much. We'll have our panelists back up here after our next presenter, so I'm going to bring up Steve to introduce the next presenter. Whoops, I think